In the third and final section of this course, we are going to use the factors we have just discussed, including health behavior change theories, to cover practical strategies utilized during motivational interviewing. Now that we have considered the theoretical basis for health behaviors, individual choices, and commitment to change, let's cover some practical aspects of motivational interviewing, including the underlying principles, process, and techniques. There is an acronym often used to describe the motivational interviewing process. It's called the 5 A's. The first A stands for assess and refers to baseline evaluation of the patient's current behavior and readiness to change. Next, the clinician provides personalized advice using a tailored approach to discuss the patient's individual health risks and the benefits of the recommended change. In the third step, the PT or PTA works collaboratively with the patient to agree upon a realistic set of short-term and long-term goals and assists the patient in developing an action plan. This plan should include strategies to address anticipated barriers or challenges. As the patient begins to engage in the new behavior, it is important to arrange for follow-up, ideally within the first 2 weeks. This follow-up should include a review of any lapses or additional barriers with revised plans of action as necessary so that the patient can continue working towards his or her goals. Successful behavior should be reinforced through praise and discussion of intrinsic and extrinsic rewards. Motivational interviewing is supported by several underlying principles. These include the belief that behavioral change is best facilitated using a collaborative rather than an authoritative approach. Collaboration conveys respect for the patient's autonomy by recognizing the patient as an equal partner with important insights into his or her own behavior, his or her own level of motivation, and the best strategies for achieving success. The second important principle surrounding the use of motivational interviewing is that motivation or commitment to change is a malleable trait. This means that motivation can be influenced by promoting a shift in things like attitudes, outcome expectations, outcome expectancies, and patient self-efficacy. Several techniques are utilized during motivational interviewing. The PT and PTA should look for ways to convey empathy. Each of us has behaviors or things about ourselves that we wish to change, and each of us faces challenges when attempting to engage in a new behavior. By acknowledging these challenges, the PT and PTA can build rapport with patients, thereby establishing a sense of partnership and shared respect. By remaining objective and non-judgmental, the PT and PTA can cultivate a sense of trust that will enable the patient to freely express his or her own opinions and ideas. A conversational tone that avoids the overuse of medical jargon is very helpful in this regard. Any technical terms and scientific rationale should be explained in layman's terms. The PT and PTA should continue speaking with the patient to ensure that these terms are fully understood. Open-ended questions can be used to learn more about the patient's viewpoints regarding health, disease, and the influence of one's own personal behaviors. Talking about these viewpoints can help the PT and PTA discover common ground consisting of shared values. The patient is coming to physical therapy because he or she wants to get better. We want the same thing, but rather than telling patients how this should be accomplished, we ask them to describe what they think will work best. We absolutely can make suggestions, but we always try to encourage the patient to consider and tell us about things that may make these recommendations easier or harder to carry out. We acknowledge shared learning by treating and recognizing patients as experts in their own care. Patients can tell us about what worked or didn't work in the past, what resources and supports they may already have access to, and what options they might prefer moving forward. Conversations using motivational interviewing include discussion of ambivalence. For example, a patient may have conflicting ideas or opinions about the need to change, contrasted with his or her own belief in the ability to change. Perceptions about one's ability to change can be influenced by perceived barriers and facilitators. Very often, there is a discrepancy between the patient's values, goals, and current behaviors. Talking openly about these discrepancies can strengthen a sense of personal empowerment. It can also foster an internal locus of control and greater self-efficacy. The main goal of motivational interviewing is to elicit a commitment to change. This commitment to change should be based upon outcomes that are most important to the patient and match his or her own personal goals. These goals should then be used to create an individual, tailored plan of action. When discussing personal behaviors and lifestyle choices, patients will sometimes become defensive. Principles of motivational interviewing enable a clinician to anticipate and acknowledge resistance to change and quote-unquote roll with it. By utilizing a non-judgmental, non-confrontational approach, the PT or PTA provides room or freedom for the patient to explore conflicting ideas or opinions, otherwise known as ambivalence to change. As an example, everyone who smokes knows that cigarettes or cigars carry negative health risks. It says so right on the package. Despite this, there are reasons people continue to smoke. First, nicotine is an addictive substance, but also consider the so-called positive effects of tobacco on other aspects of a patient's life. For example, someone may smoke to alleviate stress or to control their appetite. Other people may smoke to achieve social acceptance or to not stand out among their peers. Talking about these factors can help someone find alternative ways of achieving these effects without the risks associated with smoking. Open communication also preserves the collaborative spirit that is essential for successful patient education. It demonstrates understanding and prevents an antagonistic or adversarial relationship between the clinician and patient that can actually reduce the likelihood of adherence and compromise treatment outcomes. There are many reasons an individual may initially be resistant to change. When discussing lifestyle behaviors, patients may feel as though the clinician is being judgmental. Resistance may signify the need to defend oneself in order to preserve a sense of self-worth. In other situations, an individual may already recognize the disconnect between their behaviors and their desired results. This conflict between beliefs and actions can also manifest as resistance or defensiveness. Resistance may also be due to fear of change, or fear in recognizing and discussing potential consequences of health risk behaviors, such as links between metabolic disease, heart disease, stroke, and sedentary lifestyle, or links between tobacco use and cancer. It's also really important to remember that no one likes to be told what to do. As adults, resistance can arise when patients feel as though the clinician is trying to limit their autonomy by dictating aspects of personal choice. For this reason, it is essential to convey respect for patients and their ability to make informed choices. There are many different ways of expressing resistance. It is easy to detect when somebody actively engages in counterarguments or interrupts the clinician in a defensive fashion. More subtle ways of expressing resistance include withdrawing from the conversation, looking away, appearing bored, or exhibiting other signs of inattention. When discussing delicate topics that elicit defensiveness, some patients may stop responding to questions entirely, or may try to sidetrack the conversation by changing the subject. Although it can be uncomfortable to manage resistance, there are several techniques that PTs and PTAs can use. We can openly acknowledge that resistance to change is part of human nature, and that it isn't unusual for people to feel conflicted when discussing changes in our health behaviors. We can also reaffirm our respect for patient autonomy by reiterating our motives in assisting the patient and providing advice while recognizing that the patient is really the best person to decide what will actually work within the context of his or her individual life. Rolling with resistance keeps the conversation on track and maintains rapport, encouraging the patients to express their fears and concerns. If the conversation becomes too stressful or too emotionally charged, it is perfectly acceptable to table the discussion and encourage the patient to let you know when and if they are ready to talk about these issues in the future. In essence, motivational interviewing techniques create a dialogue between the patient and the clinician that involves open-ended questions, affirmations, rolling with resistance, and the use of summarization. These techniques are often represented by the acronym OARS. Next, we will review each of these techniques in a little more detail. Open-ended questions create a collaborative spirit by conveying interest in the patient's perspectives and input. Open-ended questions can be used to learn more about someone's readiness to change and their reasons for change, including their values, goals, and priorities. PTs and PTAs can also utilize open-ended questions to obtain further information about anticipated barriers towards the recommended behavior. Acknowledging and addressing these barriers is an essential step towards enhancing adherence. Examples that can assist the patient in making the commitment to change their behavior include questions that promote decisional balance, such as, what are the costs of changing? What are the benefits of changing? And what are the risks of maintaining the status quo or leaving things as they are? Providing advice to the patient is completely acceptable as long as the PT or the PTA reaffirms the support for the patient's autonomy. For example, before providing possible options for tobacco cessation or better glycemic management, I might say something like, there are a lot of potential strategies that you might try, but you are the only one who can decide what would work best for you. Would you like me to share what has worked for other patients in similar situations so that you may consider your options? Open-ended questions can also be used to help patients envision the best possible results based on recommended changes. Thinking about positive outcomes and talking about them with the PT or the PTA can help enhance the patient's commitment to change. Here are some examples of open-ended questions that can be used in motivational interviewing. What would need to happen in order for you to become more physically active? This question encourages the patient to consider necessary resources and possible barriers in order to create a feasible and realistic action plan. How might your life change if you were able to successfully manage your weight? This line of inquiry helps the patient envision positive outcomes of behavioral change, enhancing their motivation. What's the best thing that could happen if you were able to find time to complete your home exercises? This question also focuses on positive outcomes, but it can also elicit information about the patient's outcome expectations and the value that's placed on the possible benefits of change. Use of affirmations strengthens support and provides ongoing encouragement for patients who may have doubts, including low self-efficacy. That would be when the patient doubts their own ability to actively engage in change and obtain successful outcomes. Affirmations can convey the clinician's recognition and belief in the patient's ability, strengths, and resources. Affirmations can also be used to highlight change talk, or phrases that the patient uses to discuss their desire or need to alter their current behavior. For example, if a patient who wants to quit smoking talks about how they had a brief period of successful abstinence in the past, the PT or PTA may say something like, "It sounds like quitting is still something you would like to accomplish. The fact that you were able to stay away from cigarettes for 4 weeks the last time you tried to quit shows that you were able to manage temptations. Let's talk about strategies you can use to reduce withdrawal symptoms and build on this past success. Would that be okay with you?" Similar to affirmations, the use of reflective listening can also highlight change talk and support self-efficacy. Perhaps the patient tells you that he or she was only able to perform their home exercises 4 out of the 7 days in the past week. Rather than emphasize the days that were missed, the PT or the PTA could respond by saying something that recognizes the patient's accomplishments, such as, "Even though you have a really busy schedule, getting enough exercise is very important to you." Reflective listening can also be used to check for accuracy and allow the opportunity for clarification. For example, the PT or PTA may say something like, It sounds as though there really isn't a place you can easily perform your exercises while you are at work. Is that correct? It also shows that the clinician is listening and genuinely interested in the patient's feelings and perspectives. This type of conversation can be used to promote self-awareness. If the patient is minimizing the challenges of behavior change or engaging in self-blame, the PT or PTA can express empathy and promote better self-awareness by saying something like, "It sounds as though this has been very difficult for you." Summarization can happen during transition points or near the end of a conversation. It can link and reinforce important points of discussion. For example, when discussing factors associated with increased pain, the PT or PTA can say something that acknowledges what has already been mentioned while seeking further information like, "Now that we've talked a little bit about your stress level, what else seems to increase your pain?" Summaries can also help transition from discussing goals and possible strategies to forming a very distinct plan of action, simply by saying, "What is the next step?" In your course packet, you will find a direct link to a video showing use of motivational interviewing during an interaction between a PT and a patient seeking treatment for adhesive capsulitis. While watching this interaction, see if you can pick out the two phases I am about to describe. During phase 1, the goal of the conversation should be to elicit change talk. This means asking questions and using phrases that emphasize the desire to change, the ability to change or self-efficacy, the reasons or need to change, and the patient's personal goals regarding the proposed behavior. During phase 2, the physical therapist works towards promoting a commitment to change. Although not shown in the video, an important step is to create a personal action plan that includes the patient's goals, reasons for change, and very specific steps that he or she will take to reach these goals. The patient should have a means for monitoring his or her own progress. The PT and the patient should also agree on a time frame for follow-up so that the physical therapist can also monitor progress, provide feedback, and answer any questions or recommend additional resources in response to the patient's performance. Throughout the encounter, the PT will work to discover and explore the patient's desire to change, need to change, and ability to change. In other words, the conversation is directed towards eliciting change talk with the ultimate goal of strengthening the patient's personal commitment to the new behavior. Here is the case that is portrayed in the video. Mrs. Smith has been referred to physical therapy secondary to bilateral adhesive capsulitis. Her past medical history includes type 2 diabetes. In an effort to enhance treatment outcomes and prevent further musculoskeletal impairments and functional limitations, the physical therapist decides to speak with the patient about the importance of glycemic control. Next, we are going to discuss steps required to develop a personal action plan. Working collaboratively with the patient, the PT will develop a written plan that can be filed with documentation in the patient's medical record. The patient should also be given a copy of this plan so that he or she can refer to it between visits. The template provided with your course materials for an action plan can be modified to best suit your own practice preferences and requirements of the clinical setting. But the action plan should be designed so that it clearly identifies the target behavior and it highlights reasons supporting the proposed behavioral change. Goals that are listed should be specific, measurable, attainable, realistic, and timely. Working together, the physical therapist and the patient should identify any anticipated challenges and potential solutions. The personalized action plan can also be used to track the patient's self-efficacy or confidence level over time. It should list additional resources and supportive materials. The time frame for monitoring should also be specified, along with the patient's plans for self-monitoring in between sessions or follow-up with the physical therapist. Within the clinical environment, there can be several possible barriers towards implementing motivational interviewing. PTs and PTAs are often faced with time constraints and productivity standards. The ability to utilize motivational interviewing during a normal physical therapy session is a valid concern. However, research and my own personal experience shows that brief counseling using motivational interviewing can be completed within 5 to 7 minutes in conjunction with our usual treatment methods. Evidence also supports the effectiveness of motivational interviewing in promoting better patient adherence, making it a more efficient means of delivering patient education because less repetition is required. Patients become more self-reliant, better able to maintain and increase progress between sessions. Many clinicians also fear that talking about issues surrounding non-adherence and personal behavioral choices may create uncomfortable situations that can damage patient rapport. Ironically, the evidence suggests that motivational interviewing is actually associated with increased patient satisfaction, even when non-adherence persists or the patient refuses to change his or her behavior. This may be because the technique emphasizes a genuine concern for patient well-being along with a respect for patient autonomy. Positive patient perceptions of motivational interviewing include having a sense of non-judgmental accountability, being heard and responded to as a person, a strengthened sense of commitment, and a strengthened sense of collaboration between themselves and the clinician. Patients also frequently derive a sense of encouragement and empowerment through education and instructional techniques that feel more like coaching and less like criticism. Other potential barriers towards motivational interviewing include public perceptions towards the traditional roles of PTs and PTAs, which may not include primary prevention or patient education for health behavior change. However, the American Physical Therapy Association, as well as many patients and third-party payers, affirm the role of the PT and the PTA and our expertise in topics such as physical activity, exercise, weight management, nutrition, and stress reduction. Some of us may shy away from providing health promotion services and patient education for health behavior change because of our own issues regarding self-efficacy. In these situations, our confidence can be increased through training and better knowledge of techniques that can be used successfully to promote better patient engagement and treatment results. Finally, many clinicians and managers are concerned that motivational interviewing is not a billable physical therapy intervention. However, motivational interviewing is an evidence-based approach to patient education and should therefore be billed accordingly, rather than listed as a separate treatment modality. Facilitators of motivational interviewing within PT practice include its compatibility with existing patient interaction methods. PTs and PTAs have long been recognized for their focus and expertise in patient education. Typically, a close rapport and therapeutic alliance develops between the PT, PTA, and the patient. This rapport enables a personalized, tailored approach that works well with motivational interviewing techniques. Opportunities for follow-up and progression of action planning are also provided during most PT encounters because of repeated visits within a single episode of care. PTs and PTAs should be aware of some common pitfalls that exist when first starting to use motivational interviewing. The first pitfall comes from perfect patients who seemingly agree with everything the PT or PTA says, but still fail to follow through. Distinct written action plans, goals, and time frames can help with this by providing structured accountability. The next common pitfall pertains to our usual pattern for providing patient education. PTs and PTAs are typically trained to be expert problem solvers. We can think of a solution to any anticipated problem our patient suggests. However, this is not the intention of motivational interviewing. It is more effective to encourage patients to identify their own solutions or to choose from a list of options to find what would work best for them personally. We should also be cautious about tackling too much too soon. It is recommended that patients focus on a single behavior at a time. Another common question regarding motivational interviewing is whether it is supported by the evidence. Although this technique is relatively new to physical therapy, it has been successfully applied in other healthcare settings. So while more evidence is definitely indicated, Existing research does indeed support its efficacy in promoting health behavior change. In a sample of 76 people with low back pain, Vong and colleagues found that the use of motivational interviewing improved patients' outcome expectations and self-efficacy. This strengthened their treatment and home exercise adherence, leading to better functional outcomes, as demonstrated by less pain and increased lifting capacity. Motivational interviewing with phone follow-up also promoted exercise adherence in a sample of 19 females with fibromyalgia, leading to decreased pain and improved daily function. Bull and Milton likewise found that the use of motivational interviewing promoted exercise adherence in people who did not have any overt physical impairments aside from a sedentary lifestyle. Among older adults with chronic pain, C. Vong and Tang found that motivational interviewing also promoted greater exercise engagement, thereby decreasing pain, increasing function, and improving quality of life. These results were reinforced by a 2015 meta-analysis that examined the effectiveness of motivational interviewing in improving adherence to home exercise programs in a variety of patient populations. This brings us to the conclusion of the recorded portion of the course. Please join us for the live session that will provide opportunities to observe and practice motivational interviewing skills using case studies. Working within small groups, each participant will have a chance to utilize motivational interviewing and receive structured feedback geared towards improving future performance and use within clinical settings. There will also be an opportunity to ask questions and seek clarification. For any immediate questions or concerns, please contact Dr. Rose Pignataro using the email address provided. I can be reached at rose.pignataro@adu.edu. My office number is 407-303-9183. Thank you for your time and attention. I look forward to meeting you during the live session.